everyone. It's good to be here. I love this room. We did it once before here. Still miss the old lobby, people coming and going through. It's a little bit of a challenge. Second time this morning we're doing this we're actually simultaneously broadcasting on the internet. And we've got some slides coming up. But just to sort of kick things off, we've got an hour, we've got about 45 questions, and we want to leave time at the end for some Q&A. And I hate to start with a negative, but this is, as we look at this is Becker. Wow. That's a bad spot. Jinx. Becker's comes out every month with a pretty good compendium. You can get it on the internet or whatever. And happened to just be reading this yesterday, and it's again concerning, not for us, but what's happening around the nation. I'll read a couple of titles. Hospital bankruptcies in the first half of 2017. They list 9. A couple of pages later, they have Memorial Hermann to cut an additional 350 jobs. CHS Sullivan, which is the owners of Physicians Regional Substitute Hospitals. MD Anderson, a big cancer hospital in Houston, has cutting 1,000 jobs. MedStar layoffs, attempts to close on budget shortfall. They got 100 employees layoff. We and the board leaders speak about huge changes. We are so not there. We are doing well, which is very reassuring, and a counter-distinction goes along with us having life expectancy to the community. To this community, we've increased a 1/10 of a year. The rest of the nation's going down 2/10 of a year. Healthiest and happiest, and so on. So we are in good shape. We've got the slides going now, Zach. So we have a bunch of questions that we solicited, asked everybody to share with us, and we really want to go through the questions and the answers. Some of them are more pertaining to various special interest groups, be it a location or a profession. But nonetheless, bear with us as we're recording this now. We're going to post it on the internet. Sean's helping us with this, and his comment was he wants to get one of the early ones because if it doesn't work, we've got this afternoon. We've got 4 others after this. We'll be doing it 6 times on the simultaneously broadcasting. So the freestanding emergency department was visited this morning by a few of us, not me. I was downtown. I had a pharmacy and therapeutics committee meeting. Downtown also, we had our first breast cancer conference. Dr. Patterson, who's just joined the system, is taking patients who are coming in with a new diagnosis or a change in treatment and sharing that information with radiation therapists and medical oncologists so we can really have a cancer conference just focused on breast cancer. I've gotten normally I don't fish for compliments on my dress, but people may be wondering why I'm wearing pink. And it's not that I'm gender concerned, but real men do wear pink. And October is Breast Cancer Awareness Month. They're kicking it off tonight with a fair, and I've got a few of the other men who are involved in this. So they gave me this tie, which is the first time I'm wearing it. Typically, I have bad luck with new ties and getting food spots on me, particularly. But in any event, that's where we were this morning, and they'll be able to see this also. So if you want to, later on, if you want to see us on WebEx or on our own internet, we'll post it very shortly, and that's the address. Got hair trigger. You might have read that total joint replacement, particularly knees, about 40 to 60% of knee operations are going to be done as outpatients now, some hips also. We've been very smart in getting ahead with the total package for total joint replacements. Folks here have been involved with it. Sue Slatter and Rainey inside the hospital in terms of the device, length of stay, and getting people to get home rather than to nursing homes. So the overall package, the overall cost of having a joint replacement has gone down. Interestingly enough, NCH is the busiest hospital in Florida for Medicare patients. At one point, we were the 3rd busiest in the nation. Now we're probably in the low teens in terms of total number of hips and knees done. So we're into it. We've saved a ton of money for everybody with excellent results to get people up and walking quickly. Works out our age distribution is actually an older age distribution rather than young, so we're doing well with that. Patient satisfaction is directly related to how well we feel about ourselves. We bring our own weather. As our patient satisfaction is improving, so is our employee satisfaction. We do pulse surveys frequently. We want to see what's happening. This whole town hall and responding to questions that are questions from folks just like ourselves asking are pretty frank and pretty straightforward. So, and our patient satisfaction is improving, as is our employee satisfaction. And in terms of U.S. News and World Report, we just came in at 12 of 250 for the state of Florida. We were 17, tied for 9th, 10th, and 12th. We're still in the top decile, so if you get 250 hospitals, the top 25. U.S. News and World Report is pretty subjective. It's more like a beauty contest than anything else. A much more objective way of looking at it is what the Centers for Medicare and Medicaid Services, CMS, has come up with a star rating methodology. 5 stars is the best. We're a 4-star hospital right now, puts us in the top 12% of the nation. We were 3-star. For comparison, Lee started as a 1-star and got themselves up to 2-star lately. So we aspire to be a 5-star hospital. Patient satisfaction is what's holding us back. We've done the hard things, namely infections and falls and everything, and readmissions. And you know, there was a newspaper article about a week ago now with us getting 0 penalty for readmissions. For comparison, we got a $3.4 million. Over the past 5 years, we had 1 penalty from the federal government, a couple $100,000, which is real money, but nothing like the millions of dollars of most of the hospitals. There are about 10 or 12 hospitals in Florida that have not gotten a penalty for readmission. So we've done the hard part. So we baked the cake. We just got to get the icing right, which is the patient satisfaction, and we'll get that good start, which will be a big deal going forward. So being 12, I agree it's nice to get in the top 10, but you know, we are 12. It's still not bad. Still the highest in Southwest Florida going forward. We have a whole bunch of things going on. We are investing in employees. Think about all the blue zone things. Think about the health of ourselves. When we look at our own health, we have a smoking rate of about 1.5%. As a group, over the last 5 years, our body mass index has come down dramatically, which is a contradistinction to the rest of the nation. We've spent a lot of money on education. If you think education is expensive, try ignorance. We've got all of the President Bach from Harvard said that years ago. We've got all these educational programs. This week's Straight Talk, which will come out tomorrow, talks about 6 donors giving $55,000 to 38 folks to further their education, and 4 very poignant and passionate stories about how they're changing. Some of our folks supporting us are changing other people's lives, so we can help everybody live longer, healthy lives, which is a big deal. So we are investing heavily in ourselves and in our colleagues and in our community. And the very fact that you'll never read, I hope we'll never read about ourselves in Becker's in that way that we started it out, which is a tough way to start. So there was no big adventure in Washington. Bottom line, doesn't matter whether you're from Venus or Mars with political persuasion. Washington and Tallahassee are both out of money. We're gonna, and you folks know better than anybody, our Medicare reimbursement from Tallahassee is going down $400,000 per month starting in July. Noble and the team here, does the numbers. That's minus $4.8 million going into this last quarter of this year and next year. Having said that, we're still financially secure. Our bond rating is with Fitch is an A+, and Moody's an A2 stable. Noble and the team, Sue Slack, everyone works very carefully and closely with that. So our numbers are good. We're stable. We're fine. We've got good philanthropic support. We do well operationally. We're getting more and more efficient, and we've got engaged folks. So that even though the surprising thing from Washington and Tallahassee, at least from my point of view, is that this didn't start 17 years ago when I first got involved. Those of you who've been around for a while remember we were in very precarious financial status in the past with about 2 weeks of cash on hand in the beginning. Now we have about 220 or 30. I've got to be accurate now because we've got the folks I can't make these numbers. 230 days of cash on hand. So that's a fresh number. That, it's amazing. So we could withstand a hurricane. We could withstand a recession. We would get through these things. you have only a couple of weeks of cash on hand and you get some sort of epidemic or something else, next thing you know, it's a major change that's happening. So retention, I'm going to ask Renee to take over, and we'll pass the microphone back and forth, leaving time again for some questions.
Thank you, Dr. Weiss. Good morning. For those of you who may not know me, I'm Renee Pigpen, the Chief Human Resources Officer, and as you can imagine, we do have several HR-related questions, so I'll be up here for a little bit. So what is NCH administration doing for retention? We're really doing lots of different things. One of the strategies on our strategic plan is to look to see what it would take to become an employer of choice. And that's looking at all the incentives that we do today, and then perhaps adding some additional incentives as we look at previous winners from Baldrige or Fortune's 100 Best. So we are studying that, and it will take a while to really bring everything into place, but we're looking at perhaps applying for that within the next couple of years. We've got some exciting things that we're looking at now, and we'll hopefully be able to talk to you more about that in the future. The next question came in, and it states, what are we doing to be more competitive like our Cerner partners? And again, same thing that I just said with looking at our different opportunities for employer of choice. Will we be able to offer a 30-day sabbatical? Probably not. But there are other things that we can do and that we can look at. I'll talk about it in a moment, but one of the things that we're studying is our PTO program. So we know it's important, and we are looking at different things so that we can retain our workforce. Would it be possible to allow EIB hours to use for family time? Unfortunately, not. EIB is really for yourself, for a fellow qualified event so that you can use that. When we went to the PTO program several years ago, we actually built in sick time so that you can use that on a discretionary basis. So if you're sick, or if you have a sick family member, a sick child, you can use that PTO towards that. The EIB is really driven for your personal illness, again, with that qualified fellow event. So no, we unfortunately cannot do that. So accumulation of vacation days. This question states that our PTO banks as we have them today is a very old model. Well, in fact, it's actually standard business today to have a PTO bank that's inclusive of PTO, holiday, and sick time. Most organizations do not have an additional EIB bank that we have today. It's all clumped into one. We are looking, as we study to become that employer of choice, we are looking at our PTO accruals, and we have made recommendations to the senior team. And unfortunately, I'm not at liberty to talk about those right now because they still have to go to the board for approval. But we're hopeful that in the near future, we'll be able to come back to you with some exciting changes and enhancements in overall benefits. Would NCH consider revising the tuition policy? And this question really relates to payment up front. We've had employees ask, it's difficult for me to pay for my classes and then be reimbursed for them. Unfortunately, today we do not pay the facilities directly, but we do have a quick turnaround time. So if you are enrolling in a class and you submit your paperwork, you can elect an early payment. And that payment is turned around very, very quickly. So once you get that in, it's usually in the next payroll cycle that you can receive that. We get it, that there's a delta there, and that there is a time that you have to wait for that reimbursement, but that's fairly standard. Another thing that we would encourage is use of our scholarship programs. We just, as Dr. Weiss said, the last time we had 6 donors that gave $55,000 that we were able to offer in scholarships to help offset those payments and get that money to the employees more quickly. We do have a new scholarship program that will be starting, so we encourage you to work with the education department and see what opportunities are out there. Additionally, we have our auxiliary who offers scholarships not only to you, but to your children. So those are opportunities as well to help offset some of those costs. This is a sensitive question, and we understand where the individual is coming from. However, it is not illegal to require employees to use our facilities. It's very common with healthcare, particularly self-insured healthcare employers, to drive that business back in-house so that we can keep those premiums down for you. As care providers, everyone's taken an oath to keep information private. We often care for our family members, our neighbors, our colleagues, and we don't go out and share that information so that, you know, we're used to that and we know that. If you're uncomfortable with going to an NCH provider because you work closely with them, you're not required to go to that provider. You can, if you elect not to use them and use the copay, you can use another tier 2 provider in the network and pay deductible and coinsurance. But that's someone then that's neutral and perhaps not working as closely with you, so you do have those choices. But we will continue to require for you to use our facilities if these are things that we offer. We do approve out-of-network things from time to time if we cannot offer them, and we look at that on a continuous basis. This was actually a question that also came up in the April town halls, and it relates to life insurance for our spouses as well as the declining in coverage as we age. So we did study it over the last few months, and we found that our life benefit is very competitive, and we will not be making any changes. We will keep that at 70. Typically, book of business is for a spouse coverage to end is at age 65, and we are at age 70, so we do exceed that benefit, as well as spouse termination. That is also at 65, and we are at 70. So both for spouse termination and decreased life benefit for ourselves, it will stay at age 70. This is from a unit secretary, and it talks about you know, his or her wage and the opportunity for affordable housing, and would NCH be getting into the apartment business again? And no, we will not be getting into the apartment business. We do understand that workforce, affordable workforce housing is a sensitive issue. It's something that we, in fact, are working very closely with the government, the county commissioners, the other service employers, and we meet monthly to talk about different things and what we can do. It's called the stakeholders meeting, and we actually engaged with urban land development this past early year, I guess. Dr. Weiss and I both interviewed with them to talk about what it means for our staff to have affordable housing. You may have seen signs that say NIMBY. Has anyone seen a sign that says NIMBY? Well, that's not in my backyard. So that's some of our more affluent areas that state, I don't want affordable housing or service employees in our area. So we have a campaign now going on that's YIMBY, yes in my backyard. And as a matter of fact, one of our nurses just participated in a video that talks about NCH and the need for the affordable housing. So it's not an overnight fix, but it's something that we're working very strongly with. Yes, sir. I think we're going to take questions at the end, if that's okay.
Okay, so from you, Terry?
Pardon me?
So I can direct them to you, correct?
Absolutely, absolutely, thank you. So be assured that we understand the urgency, and we will be continuing to work closely. Staff transportation program. This is actually one of our Blue Zone initiatives, one of the pledges. As you know, we received our worksite certification, but that's not a one and done. So we have to continue to recertify, and this is one of the areas that we will be focusing on amongst others. And that is to offer some type of transportation incentive. With the housing, we know people are moving farther and farther away, so what opportunities do we have? So the Blue Zone Committee is going to be presenting information to the senior team within the next quarter of things that we can look at. So more information to come on that. This question relates to the gym, and it talks about infection prevention. And absolutely, you know, we do work with infection control. We've actually asked to get on their annual inspection. Some of the concerns were the dirty vents, and we understand, and we're working with engineering and environmental, but they need to bring a lift in after hours in order to get up and clean. If you've been to the Walmart, you know the ceilings are extremely high. The other thing is the tiles in the men's and women's locker room. It's an old type of tile where there's like a glass on top of the tile, so water gets in there and it molds. So we are making recommendations to change that all out. It is cleaned, it is scrubbed daily, but it gets down in and you just can't get in there. So hang in there, it's coming. And then, I think this is my last question. Employees working full-time, having opportunities to use the pool and the water aerobics. Unfortunately, right now we cannot offer evening and weekend classes because we don't have the instructor availability. So if you know any water instructors and they're interested in working, please send them our way, because then we would be able to open that up and offer more opportunities. And now I'm going to turn it over to John.
Thank you, Renee. Good morning, everybody. I'm John Kling. I'm the Chief Nursing Officer for the system, and this is my second town hall, and appreciate the opportunity to come and talk with you guys. Some of these questions are obviously nursing focused, but really they are applicable to you all as well. So if you look at this question, it really talks around retention and reimbursement. So the question says, can you explain what NCH considers retention and reimbursement? So if one brave person can tell me, what does retention or reimbursement mean to you? No wrong answer. Anybody? Lots of them, I think I heard stay working here, right? That's as simple as you can put it. We are doing a lot of work around this. We're going to talk a little bit about the next slides, but retention is really important for the entire organization, not just for the nursing department. Every employee with these averages about $55,000 in cost. They're trained and do that, and then the added stress on you guys. So we are very focused in our efforts to improve retention. Next slide, please. So this question, the answer simply is yes. We have a process we're putting into place that will allow for proactive scheduling of shifts in the inpatient acute care hospitals to allow us to schedule, be more efficient with our scheduling, and staff know when to get things covered at home for the work-life balance issues that happen. So the question we had in this morning's forum is that will this be across multiple areas? Yes, it's if the department director or the team can figure out how that's applicable to them, we're more than willing to work out that within their areas. So this is, in referring to the first question I had, there was a question about what is done to reward us. So we had a seniority perks committee that's been meeting for about the last 6 months, and 329 senior nurses, or tenured nurses I should say is a more appropriate word, sat down with us for many weeks and went through a lot of recommendations for some perks, both monetary and non-monetary, that can be offered to that. So rolling out very soon, we'll have some opportunities that if you guys look at some seniority perks across the organization. The perks committee never stopped meeting. They just didn't look at their email, unfortunately, but we finished up our meetings last Friday. And then what is being done to reward senior employees? And today, they have higher PTO accruals. Some areas offer scheduling, floating type of benefits already. There's lots of things out there. But as we roll out the seniority perks, there'll be more to come with that. So this question is a little bit odd because we have for a long time recognized certifications with pay, and we do that through our Aspire program, our clinical ladder. And really to put it in perspective in very simple terms is the program asks the staff to give back to the organization, most important to the patients, by working in quality programs, quality initiatives, unit-based staffing groups, things like that. By doing that, it improves the care. Dr. Weiss mentioned our 4-star. We believe that has a direct impact on our quality, that we are encouraging them and rewarding them to be more educated. Evidence shows that with higher education and certifications, mortality and morbidity decrease significantly. And by doing this program, certifications are very heavily weighted into the clinical ladder. And we offer once a year during Nurses Week, 2 to 4% bonus on their gross salary based on this clinical ladder. And again, the certifications are probably about 30% weighted in that, so very significant in that. So this question here, so every year we analyze nursing salaries and charge nurse salaries through the compensation committee. This question is definitely not apples to apples. There are different job descriptions, different requirements. So I have asked the person who wrote this letter, please come and sit down and talk with me. It's definitely not like for like. Again, as we mentioned, every year we look at the job description, we reevaluate the salary to make sure that we're fair across the system. So this question came up really from some of our senior staff, and the first question around pathways. So SDM is shared decision making, and really that's an evidence-based process that allows the frontline clinical staff to lead processes and not being driven by the administration. So what we've heard from them loud and clear is that they feel like the initial premise of our theme was leave your title at the door. So that meant that the CNO had no more power than the unit secretary, which is what it should be with shared decision making. The perception is that's morphed into more of a nursing leader-driven process. So actually next week, we will present the revised SDM process that will kind of streamline it and put that value-added work back into it for the staff. If it's not value-added, why are we doing it? So and this has impact across the organization, not just nursing. So who here has heard of the hiring freeze? Most of you. So really it's more of a frost than a freeze. So Dr. Weiss opened up the talk here today talking about other organizations and their financial woes, and their reaction is typically to cut, right? Do a riff, lay people off. So we sat back and intentionally looked at the natural progression of employees leaving the organization. It's about 80 employees a month leave for various reasons: relocation, graduation, moving up in different organizations. So we really looked at, and at that time, revenues were really declining, volumes were down, reimbursements were down. You guys can all attest to that. So you had a really a focus group that said, instead of mandating that we're going to lay off X number of employees, let's let natural attrition help us with that and not replace. So we focused on the people who are here, our family, which is you all across the system. Did that put some burden on some areas that had higher turnover? Sure, but we didn't want anybody to have to come say, you have to lay off your employees. We wanted to keep our employees here. And as volumes now have increased, so have our postings. So there was only a couple of weeks where we had very few postings or zero. For the nursing department, I currently have 35 positions posted as we start to ramp up for a season. As an organization, there's 184 positions posted currently. And we meet 3 times a week with this small committee to review all of the positions and their appropriateness in the organization. So it was a cost-conscious move in an effort to retain current employees and also remain financially responsible. So all the things we're doing here are really to do that. The extra shift and stuff I talked about allows us to keep our staff here and not go work with other organizations part-time or per diem. And we can hire less because now we know that we're consistently going to have more staff available to care for our patients. So less benefit costs and the reward back to our employees.
Well, good morning, everyone. I'm Gary Thompson. I'm the Chief Experience Officer for the health system. I have a few questions that were addressed I'd like to respond to. Before I go into that, I just wanted to extend my appreciation across the entire health system. We have had a very good year in that patient experience. You know, our core value is to deliver excellence in every patient experience. We have some of the best results when you compare ourselves, particularly in the emergency department and in our clinics and several areas across in the nation. So Every one of you make a difference in that, whether it's a patient who calls back, has a question on their bill, on the back end, all that ties into that experience. So I just want to say that to say thank you. The first question I wanted, it may apply to many of us, is can I go on my computer and surf the internet during work hours? We have a policy for that, a usage policy. Very simple. If it's your break or your lunchtime, and it's not tying up a resource that someone may be using, yes, that is fine. But during working hours, we want you committed to doing what you're here to do and deliver that excellence in what you provide. Next question, Zach. This is a great question. I know this is for many of you here. This is kind of connect the dots with that. But we have two, as you know, two cafeterias at our hospital campuses. And within those cafeterias, they provide blue zone type meals. And you'll see on the next slide, we have a lot of offerings that we have. In fact, look on the right there, you'll see 44 items that are rotated on a 5-week schedule to ensure across both campuses that we have offerings. And on a daily basis, you look on the left, you can see. So there's offerings for vegetarian and for vegan. With Carlos Marrero and Mark Flood, who lead both of those campuses, if there's something specific, whether it be vegan or not, that you would like to see them potentially place on the menu, please let them know. They're very creative, and they're more than willing to try different things that will meet the needs of our employees and visitors with that. The next question, I was glad to see this arrive. What it tells me is that those employees and leaders that have went through, this year we launched a service excellence training where many of our clinicians, bedside staff, support personnel were asked to attend the service excellence training. One of the components of that was how do we greet our customers? And that customer could be me walking down the hall, I got to see a name, seeing Laura, and how do I handle that interaction? And from a leader perspective to a staff perspective, it's very simple. If you go to the next slide, you'll see it listed as a 5-10 rule. Our expectation is very simple. At 10 feet away, I provide you with eye contact. Very simple. 5 feet, I'm not going to use a measuring stick here or anything, but when we get close, we need to approach an interaction. That could be good morning, that could be good afternoon. That's how we treat customers here, and the fact that someone brought that forward tells me, A, they were listening. I don't know who the big guy is they're referencing. Maybe I'm the big guy, I don't know. But we look at it more importantly as that's our expectation, one expectation of you. And if I ever passed you in the hall and I didn't greet you, I want you to hold me to it. I want you to nudge me because that's what we aspire to do that. That's what we want our visitors, we want our patients, everyone when they recognize. And I can assure you the culture is changing. Dr. Weiss could probably share some recent stories, and many of us can, of the patient and family comments we're getting about the friendliness in our environment. So we thank you for that and what you do.
Good morning. So I'm Phil Dutcher. I'm the Chief Operating Officer of the healthcare system. I know how I greet people when I meet them. And frankly, I have favorites. So when I go to the North Naples campus, Leon behind the grill, he's my favorite up at the campus. And when I go to the Baker campus, Annie Sheridan, the administrative receptionist, is my favorite because she always has chocolate out on her desk for me. But the most favorite employee of the entire healthcare system is here at the Central campus. And I'll let that just soak in and you guys can all think about who that might be. Karen Laban, you want to stand up, please? Okay. Why don't we pick up the Baker campus and what are we doing with construction? You hear from me all the time about where we are with some of our renovation construction projects. The Baker campus, we have a big second and third floor master plan renovation going on. We're in the tail end of phase 4 right now. Phase 4 is doing 2 operating rooms, upgrading 2 new operating rooms, creating a new endoscopy center on the 2nd floor. Currently it's on the 3rd floor, the east end of the 3rd south floor, but it's going to be moved to the 2nd floor. And then we're looking to develop a generic, or I guess I'll call it generic pre-op, post-op area for surgery, endo, and cath lab. And half of that will be done with this phase, which will complete in October. The next phase is 5 and 6. 5 is the renovation of 3 South into a new state-of-the-art intensive care unit. We woefully need new modern ICUs down at the Baker campus. And then phase 6 is the second half of the pre-op, post-op area. So that will be completely done. And those projects are going to start in a couple of, 6 will be completed. It's a little easier project, and then 5 will be about half done this fiscal year. We're also working on the emergency room down at the Baker campus. We will get started. We've already started with some of the preliminary design work, and we expect to get started on that project this year. So renovating the entire ER down at the Baker campus. Imaging. My friend Jim Bates, the department chair of imaging, came up as not having any department meetings. Well, you've heard John Kling talk about all the meetings and focus groups he has with nursing, he and his executive team. We want that to happen throughout the entire system. And so when I brought this subject up with Jim Bates and asked him to see his schedule of meetings, he quickly came up with a list of meetings in September that he's going to have with his staff. I don't know if he was already planning that or this question spurred him on. But anyway, the people, not many of you probably work for radiology here, but they're going to have departmental meetings, as is all the departments. And I would encourage any department director to make sure you're actively communicating with your staff. Walking path at North Naples, once again, probably not a hot topic for this group here. We are going to start that project this year. We put money into the capital budget, and we'll start that work yet this fall. I know there is concern, and so we'll wait for the questions, but I know there's concern on this group about a walking path, a safe walking path, and an area for you to go out and eat outside. And that is part of our capital budget considerations this year. So we're building an opportunity. Frankly, we're trying to figure out how we can do a walking path around the perimeter of the fence, but make it so that it works and you don't get run over by cars and all that. But anyway, we also know that there's the issue of an outside dining area so people can go out and it would be shaded and what have you. We're the most wired facility for 7 years in a row, but we can't get my computer fixed. You know, let me offer a little bit of an excuse, because there probably are some IT people here in the room. Every day, our IT help desk gets hundreds of issues, complaints brought up to them. From, I can't remember my password, to my computer doesn't work, whatever. So all I would ask is, I mean, we do have a process, and I do want to encourage you to use the help desk. That really is the most efficient way of doing it. If your problem is a priority issue, I can't do my job without this computer, so I'm just sitting here twiddling my thumbs, make that known to the help desk person. And I suspect you do, but make sure you make that known to them so that they know that it can be put on a priority basis, and we'll attend to it as quickly as we can. Some things need to have approval, and I suspect this question didn't come from something like that, but again, you know I noticed today when I stopped in Brett Donbach's office, he has 3 monitors. I can't imagine how you can look at 3 things at one time, but anyway, like questions for dual monitors and stuff like that, that takes your department to make that request. So anyway, we'll work on this. We talk to Cerner all the time about their performance in help desk complaints. Fishing, as I told somebody, I'm getting way beyond my capabilities here in IT. But like you would at home, number one, when you see something that looks fishy on your computer, I wouldn't open it. I never do. I always, if I see something unusual on my computer that just does not look right, I send it right to Andrew Cooper, and say, Andrew, is this spam? Is this something that, yeah, but I never open it. And I would encourage all of you, don't do that. If you've ever been, a victim of some kind of violation in your computer and stuff like that, which I have. Unfortunately, it's not fun. Let me do parking. So parking, really, we do have rules and regulations about parking. Parking is always an issue. Downtown at the bigger campus, they're always complaining, and then I have the security department go up and look at the different levels in the parking garage, and they tell me of all the hundreds of open spots, and nobody wants to be the last car in the top spot. We understand that, but we do have rules and regulations about parking. We would like our employees to park in the parking garages. That's the most safe place. We have plenty of security cameras. You'd be amazed at how many cameras we have throughout our healthcare system. Literally thousands of cameras. So that's the safest place for you. Obviously, that doesn't apply here. You guys got all surface parking, but well lit, and we do have cameras here as well. Ooh, that's right. Yeah, you can have that.
You didn't want to take on the billing question? Okay. If there's anybody out here who doesn't know me, I'm Rick Wiles. I'm the Chief Financial Officer here. I think most of you do know me because I spend a lot of time up here at Central Campus. At least that's what I tell my colleagues anyway, so they think I spend a lot of time up here. So I was excited to actually get a billing question near and dear to your hearts here. Really, the question relates to a lot of folks say, I don't have the information to efficiently bill, and whether it's documentation or whatever. And as you guys well know, billing is a very difficult process. And as soon as you have something fixed, your insurance company changes it. So it's a constant moving process. But having said that, we are completely revamping our billing process. We started about a year and a half ago. And as you know, we had a billing group that billed for the hospital and a billing group that billed for the physician group. So we started by putting them under one leadership, which is Sandy Wood right here. Did that I think about a year and a half ago. And then I think in January, we moved the physical location. So you guys are all located in one spot. And I know that's helped a lot. The third step, which we're working on right now that you guys are sweating over is changing the billing system for the physician group to Cerner. So we're going to be on one billing platform for both the hospital side and the physician side. It should help with a lot of billing efficiencies for everyone. Very difficult process. That's due to go live in January 4th of 2018 at this point. Appreciate all you guys' work on that because that is a lot of work to get that up and running. But as part of that, we will continue to work on our processes and really having the most efficient processes that we can do. We brought in Cerner. They're looking at our processes. They do this stuff all over the country. So the goal would be to get our billing as efficient as possible. I think we're moving that direction. Never get there, but certainly I think these steps we are taking are really going to help us a lot, and I appreciate all you guys' efforts in that. Okay, this is really a tough question. Can managers have additional training in the budget manager system? As you guys know, we've had a long-time budget director, Jerry Markham, here. He retired this summer, and so we have a new budget manager in here. Her name is Lori Smith, and Lori is open to personal training for any manager who would like it. And so we'll send out her email address, and so anybody that needs some additional training can certainly get with her, and we're happy to do that. Okay. I think this next question, that's to Zach.
Good morning. I'm Zach Boslock. I'm the Chief Administrative Officer. I work with our employee positions. There's a few questions about the group. This is specific to a facility that we refer to as the Commons. We have 3 different operations there. We have a family medicine office, we have an infectious disease office, and the radiology department has a large presence there. We have about 34 different locations for the physician group. As we look at master facility planning, when leases come up, we consider if there's a better location. I'll just use what we're doing down the southeast side as an example. The Edison location is one of our most expensive locations. That lease came up recently. We've decided to build a new building, which is closer to 41 and 951, where we're going to be able to provide more services there. We're calling that NCH Southeast. The Commons location, that lease is up was up as of the end of July, mid-July. We've renewed that lease for another year because we're going to consider either staying there or repurposing at least one of those operations someplace else where we have open space. So there's not a defined timeline as to when we may move an operation from there. For the time being, we will stay. So yeah, all the doctors haven't left. Now, if you work at Veterans Park, it may feel that way. So at the Veterans Park location, we've had a decent amount of transition from that spot. We had 2 physicians that we repurposed to Morris Park. Morris Park asked us if we would take over their clinic and introduce our concierge medicine program in that clinic. So we moved Dr. Contreras and Dr. Goldstein to that spot. Additionally, then we added a physician there, Dr. Panisi, to offset that, so we can take care of those patients from those 2 practices. But then we had 2 of our family medicine physicians give notice, and they left the state to go back to where their families were. Additionally, we had our pain management physician who worked with us for about 6 months. His wife became pregnant, she wanted to be closer to family, so they left to go be on the other coast. So again, if you work at that park, it would feel like all the physicians are leaving. We are working to add other physicians in that location. As far as overall turnover for the group, if you look at the providers, the group is 3 times the size that it was back when we first started. So you're going to expect a little bit of turnover, more than what we had back in the day. We had 50 providers. As the group is now roughly 220. But for job security, just to reference a stat about growth, we've added 51 providers already this year. So NCH Physician Group will continue to be a growth story. Insurance, I know Renee touched on this a little bit. So just the physician group, its purpose is not to have providers in the group in order to provide co-pay structure within the benefit plan. It is a nice benefit that we're able to provide by having the employed providers. The other benefit that's there, the HRA points, that can go towards your deductible for physicians not in the group when that applies. And I did some math without a calculator, which is dangerous for me earlier. So just so quickly, if you were going to go see a neurologist, you're doing follow-up visits, and you guys know these numbers better than most, so I have to make sure I get close on this. Rough number, about $100 per encounter you could expect. So if you had 10 encounters, that would be $1,000 that would go towards your deductible. You have up to $1,000 that you can earn in HRA points, which means it wouldn't cost you anything. If you compare that to the copay structure, if we had a neurologist in the group, you would spend out of pocket $45 per encounter, so $450. So either way, you get a nice benefit by way of the HRA points for docs who are not in Tier 1, and with the copay structure, should they be. So this scenario is in regards to us pulling staff from their home base and repurposing them someplace else. And the question is, would we do that if there's a provider in the practice that needs support? I talked to Todd Line earlier about this. Todd Line is our Assistant Director of Operations. He handles floating staff from location to location. He said he couldn't think of a scenario where this would happen. The only thing we could come up with would be if there was a timing issue when we committed a staff person someplace else, and then a provider decided to work that we didn't anticipate working. It also could be a specialty issue where we had a staff person, whether it be RN, LPN, or MA, that has specialty focus that we needed someplace else. But that would be a rare event.
I'm back. First and foremost, who attended the Fun Splash Water Park? Anybody? Great, it was a good time. If you recall, about a year ago, we did a survey with all employees and we asked, what would you like to see? And they said, we'd really like to see things spread out amongst the year. So we did hold the water park on one Saturday with the intentions of holding another event at the zoo in the fall, and we had a lot of feedback that what happened to the back-to-back weekends? Well, that's what happened. But taking that into consideration, we have confirmed, and that's why it's kind of the last slide, last minute yesterday, that we have booked the Naples Zoo for 2 back-to-back weekend dates. So it'll be Sunday, October 8th, or Saturday, October 14th. And there'll be information coming out on that. The best part about it is that it's going to be a 9 to 5 event. So you can come anytime you want, as well as if you want to come on both days, you can do that as well. So we don't have to worry about inclement weather and other things, so it's your choice when you want to attend. We will have a sign-up that will go out, or a registration table when you come in. You will need your badge, and we'll offer water and snacks again. We will not be doing the food. We had some feedback on that as well. We also had very positive feedback on the snacks. So stay tuned for more information. That will be coming up. 2 events anytime, you and your immediate family, just like the water park. Okay? And then lastly, just encourage your friends and colleagues to attend the town halls. After the town halls conclude tomorrow, we will be posting all of the questions and the responses out on my NCH, as well as the video that we're doing today. So you will have an opportunity to look at that. As well, remind people about the WebEx for the upcoming town halls. It's working, it's new, we've not had a lot of participation, but I think people just need to get comfortable with it. So thank you. With that, I'll turn it over to Dr. Weiss and we'll open it up for questions.
Thanks, Renee. Thanks, everybody, for being here. So what's on everybody's mind? Please.
Could we get an education fair here? They're always at the hospitals and it's not convenient for us to attend those.
I'm going to repeat the question for our webinar. So can we get an education here on NCH Central? It's usually at the hospitals and it's just hard to get there. The answer is, I'm thinking yes. We've got great facilities here and we'd be happy to be ready. John?
So as we expand the physician group and look at the growth of the organization and kind of getting out of any silo type of environments, that question I think hits to that. And Ilya Echevarria, our Associate Chief Nurse for Professional Practice, is developing a new model for education for the organization, Center for Innovation and Learning. So as we look at that, Phil Dutcher, our Chief Operating Officer, and I were talking about that it puts everything for the organization from soup to nuts kind of in the view of that person, so on that program. So I'll take that feedback back to the team and we'll look at how we can integrate that. Great question.
Other comments, questions? Please.
I interrupted Renee before. With regards to the question that was posted, on the housing, could it be that they're referring to cost of living expenses or consumer price index?
They're looking at everything. Some of the recommendations from the urban land development actually was to look at wages and all of that. So there's not a piece that it didn't touch. It's just a matter of working through all that right now and things that employers can control. We look as an institution at wages on an annual basis. We participate in compensation surveys. We have benchmark positions that we look at, so we're always looking and evaluating that. Thank you.
So just a slightly different take. Collier County, of the 67 counties in Florida, has the lowest crime rate. We've got the longest life expectancy. We're on the radar, so what's happened is people want to move here. More people chasing less real estate, prices go up. So one of the solutions, which is politically hard to get through, is to ask our elected officials to raise the taxes a little bit for people who are living in coastal Collier County, basically in very expensive areas. So we have an extraordinarily low real estate tax for high-end property. That would help everybody. So then if you get those folks paying more taxes, and we can pay our firemen and our police and so on a little bit more money, and would help everything. So you just got to redistribute things rather than getting the haves and the have-nots, which is a bigger political problem. If you got other politicians willing to do that, typically they're not willing to do that. Other questions? Please.
Can you talk about the microphone?
No, we need to get to the question.
In regards to the scholarships, I have looked and I've seen, looked at different avenues, but there's only auxiliary scholarships and like nursing scholarships. There isn't a broader term for just everybody. Is there a way that we can get something like that for people that aren't auxiliary or nursing staff?
So if we can get your name to somebody in the organization, back to myself, I'll get back with you. But we have, we mentioned earlier, we had some very fortunate to have multiple donors donate about $55,000 we passed out scholarships last semester. And that included many ancillary department people. There's specific scholarships set up for non-nursing funds. So we'll get with you. That's available out there to our organization.
Other comments?
Can you list them to make it a little easier to find? Because I've looked and I've only saw the two. Maybe possibly.
Yeah.
Thank you.
Yeah, make it easier, absolutely. We want to facilitate that. The other thing is the donors get a real charge out of helping other people and changing lives. So and we have great donors. This year we're on forecast to get close to $16 million worth of donations from philanthropy. Our best year ever was about 34 million. So, getting people into scholarships is a big deal for everybody. Please.
My question is about communication. The physician group is always bringing on new providers. There doesn't seem to be any announcements about new providers joining the group and what they bring to practice or to the group, or what services how it benefits the employees.
Great point. We can do better. So two recent examples. That makes sense. I give it to Zach. So we just, Dr. Patterson, she is a board certified fellowship trained breast surgeon. She just did a breast conference this morning, the first one getting that organized. Dr. Scott Thompson is a sports orthopedist, did his undergraduate at Yale, Harvard Medical School, Columbia Orthopedics, and then was back in Boston did a sports fellowship. And he was a sports doctor for Boston University, or Boston College, but you get the picture. So we're bringing on great people. But we got 50 people to talk about.
Right. So I don't disagree. I know this has come up before. I think we made an attempt to do better. Somehow it fell off. I've got a meeting with the team later today, so we will revisit that and we will do better and communicate.
It's an embarrassment of riches that people are coming on board. So which is great. We gotta get that message out not only to ourselves but the whole community. Life's changing dramatically, and Zach touched on it. Even if you look at our income, we now get about over 50% of our income as a system comes from the outpatient area, like 55% looking at somewhere in that. And 10 years ago it was, and you did the number, it was like 95 inpatient, 5% outpatient. We added radiology and all these other positions, so it's a big deal. Please.
Probably to Zach, but can you tell us anything about the changes that are coming down with our lab locations?
Yeah. So it was, I think, a couple weeks ago where I had a meeting here with the lab staff and we talked about changes. So in order to make the practices more nimble, in order to add benefits to the practices, we eliminated some phlebotomy positions, and we are replacing those positions with MA positions that can draw blood. And we've been encouraging the phlebotomists as we go through this transition to get their MA certification so they can stay right where they are. But that is a transition that's going on, and just give you kind of an example of why we think this is going to make a big benefit, or will benefit the practices in a big way. So in the afternoon, when phlebotomy slows down, those staff that just have phlebotomy skills are there waiting for someone to come in, but often we don't do much in the way of blood draws after 2. Now those folks, as they're going to be repurposed as medical assistants, they can float out on the floor, they can help ensure that we don't have overtime because they can cover other medical assistants. So that's what's going on across the group. We are not shutting down any of the locations where we currently draw blood. I think that there was some discussion about that, or at least some rumors came out. The Commons, Eagle View, Vet Park, all of those big locations will continue to draw. There is one location that we're looking to probably not provide that service on a regular basis, and that's Marco Island. The average number of blood draws in Marco Island are 8. So it's hard to justify having phlebotomists down there to do 8 blood draws. But we will probably still draw blood, at least sick blood, and that will be with medical assistants on site. Does that help?
Yes.
Thanks. We're going to go right to the last question, and then we'll hang around a little bit. Anybody has some other comments?
Thank you. My question is to Big Pen about the employee pension. I'm just wondering if there used to be a program when you could give up certain benefits and there would be different tiers for that, that you would get like more hourly pay. I'm wondering if you're looking at that, maybe bringing some of it back or something like that? Because some of us don't get benefits from here. So.
Right. That is actually something that we studied this year to look to see if we could have a benefit such as an opt-out benefit for health insurance. And it's not something that we're moving forward with this year. It's something that we're going to continue to study once we see what's happening with Obamacare and availability, because it's difficult to police who has insurance and you have to validate the insurance. So for total transparency, we feel like we need to wait a little bit longer, but it's actually on our list of things that we reviewed and we'll continue to review. So thank you for asking that.
Thank you. One more question, sorry. I know that like nursing, they benefit from having certified, but there are a lot of different coding and billing certification that we could get. I'm wondering if we could, that would be an incentive either hourly or like a one-time reimbursement or something like that.
It actually came up at the last session. It's something we can certainly look at. We have different certification programs for different disciplines and different career ladders and such set up. So work with your manager, have them contact us, and we'll see if there's any opportunities there. But we do have quite a bit of that in the organization. Thank you. Welcome.
Thanks, everybody. Thanks for being here. Thanks for what you do every day. We've got a great system, and you all are what makes